All right, Assalamu alaikum everyone. I'm Salsabil, a fourth year medical student. And in this session, what we're going to try to do is practice a few physiology GI questions, but also I'm going to give you like high yield information from each lecture so that by the end of this session, you will be you'll have a comprehensive knowledge of all of the sessions or all of the lectures that you took in GI. All right, inshallah, so let's begin. If you have any questions at any point, let me know, please. All right. Okay, so starting off with a question. So newborn initially healthy begins to have bullous emesis and fails to pass meconium during the first 48 hours of life. Emergent abdominal barium study is performed during the time and results are shown. Which of the following is incorrect about the presenting disease? I'll give you a minute to answer. Okay, C. We got one answer, which is C. Let's see if it is correct. One second. And yeah, it is correct. It is C. So a bit about Hirschsprung disease. Just a second. Yeah, a bit about Hirschsprung disease. It is caused by defective neural crest cell migration in both the submucosal and the myenteric plexus. So here, the option says that it is only in the Auerbach plexus, but the presence of Meissner's plexus causes this disease, which is not true. Both Auerbach and Meissner's plexus are absent in Hirschsprung disease. What else? So you would see delayed passage of meconium, you'd see constipation, abdominal distension. It is also associated with Down syndrome. And when you do biopsy of the rectum, you will see aganglionosis or absence of ganglion cells in the affected segment. All right, this is about Hirschsprung disease. Let's move to the next question. All right, I'll give you a minute to answer. It is about which physiological effects do the GI hormones have at normal concentrations on the gastric acid secretion. Okay, C, I forgot. Okay. All right, so let's get into it. Is it C? Let's see. It is B, in fact. Okay. So which of the following, it says that which of the following has a direct physiological effect on the various of the various hormones on gastric acid secretion? I'm sorry, this chat box is obstructing my view. All right, so we will go through a bit about each of the hormones, but before that, the correct answer is B, which means gastrin stimulates gastric acid production, which makes sense. Then secretin, it inhibits gastric acid secretion. Cholecystokinin, it has no effects. It mostly works on the gallbladder. Then GLP also has no effect. It also inhibits the gastric acid production, and motilin has no effect. All right, so let's see a bit about each of these. I know it's a big table, it's a very busy table, but I'll go a bit about each of these. So gastrin in gastro means stomach, and that's where the name comes from, right? So it is secreted by G cells, and it causes everything to increase acid production, increase gastric motility, increase gastric mucosa in general. So it increases everything gastro. That's how you can remember. Then you have cholecystokinin, which is secreted by I cells, and this is responsible for everything in the pancreas. So it increases pancreatic secretion, increases pancreatic mucosa, tropic effect on pancreas, which means it increases the growth of pancreas. However, it does not have any effect on gastric secretions. Then you have secretin, which is secreted by S cells. Now, secretin, as the name suggests, it increases secretions. What kind of secretions? Mainly bicarbonate secretions from both the pancreas and also the biliary system. However, it inhibits gastric acid production. All right, so this is something. So secretin inhibits gastric acid production, whereas gastrin increases gastric acid production. Makes sense. So myostatin, how I remember this, it's basically a hater. It inhibits everything. It does not like anything. All right, so it is secreted by D cells of the gastric mucosa or delta cells of the endocrine pancreas, and this decreases hydrochloric acid secretion, pepsinogen secretion, pancreatic secretion, decreases gallbladder contraction, decreases insulin. It decreases everything basically. All right, and that is a bit about those. Then you guys can go through, this is from your lecture, so you guys can go through all of this. We have ghrelin, for example. It sounds like a gremlin. It makes you hungry. It is produced by D1 cells of the stomach. It makes you increase in growth hormone and increases your appetite. All right, whereas leptin, on the other hand, it decreases your appetite. All right, then we have the next question. I'll give you a minute. 50-year-old woman presents with postprandial epigastric discomfort, excessive gastric acid production. Her symptoms worsen with acidic food, but improve with bicarbonate intake. Lab results show increased pancreatic bicarbonate secretion in response to duodenal acidification. Which of the following hormones is primarily responsible? The answer is D. You're right. Okay, so we went through the enzymes before, so I'm not going to spend much time on this. Next question. Which of the following best differentiates the long and short reflexes in the GIT? I'll give you a minute to answer. Okay, we have an answer B. Let's see if it is B. It is B, you're right, good job. Okay, so the difference between long and short reflexes is the involvement of CNS. So short reflexes are not are within the enteric system and they do not involve the CNS, whereas long reflexes they involve the CNS and they are, for example, the gastrocolic reflex, gastroileal, what else? The vagovagal reflex, etc. Those are all um, long reflexes, and they require afferent and efferent signaling through the CNS. So answer B is correct. All right, so this is the video that I used to prepare for this lecture because I completely forgot everything from first year. And I think this is a very, very good video. It is very long. However, if you speed it up, if you go through it, it really clarifies all the concepts on lecture 1 and 2 that you have. And yeah, so I highly recommend this video. All right, next question. A scientist is studying the effects of flow rate on the composition of saliva. Which of the following best describes how saliva composition changes at high flow rates? Okay, not A, not B. What could it be? B. Okay, let's see. Um, okay, let's see D. No, the answer is B. Okay, so for this, I will come back to this when I'll recap the lecture, but just let's solve the next question and then we'll do the next lecture, the recap. So a researcher is studying the effects of autonomic nervous system activation on salivary secretion. Which of the following conclusions can be correctly drawn? Okay, let's see if the answer is D, and it is D, right? Okay, so now we'll go through the basically a recap of this lecture. So this lecture talks about mainly the uh, digestion, the first part of digestion, which involves the salivary glands, right? So salivary glands, the main glands are parotid, submucosal, submandibular, and sublingual. Okay, and the production of saliva, it starts from the acini and then it goes to the ductal cells. Now I'll try to answer the question that from the MCQ before. So when it is produced from the acini, it is very isotonic. Okay, so it has the same electrolyte and water concentration as the plasma. However, when it goes through these ductal cells, what happens is you have reabsorption of sodium chloride and bicarbonate, but you have secretion of potassium. So what happens is as it goes through the ducts, more of these solute sodium chloride, bicarbonate, all of this kind of goes out of this. Sodium and chloride, not bicarbonate. It goes out of these cells. So now the electrolyte concentration of the acini or the saliva in the duct decreases, right? So it becomes more hypotonic compared to the saliva in the acini or compared to the plasma as well. Okay, and you have higher concentration of bicarbonate and potassium in the final saliva. So the final saliva is hypotonic and it has higher concentrations of potassium and bicarbonate. Okay, so what did they say here? What was the question? The question here was describe how saliva composition changes to at high flow rates. So what happens at high flow rates? At high flow rates, there will be less time for the saliva to pass from the acini to the ducts, right? So if the saliva passes or spends less time in the duct, that means less electrolytes will be reabsorbed from the saliva. So in the beginning, when saliva was isotonic, it will still stay isotonic because not many electrolytes are removed from the saliva as it spends very less time in the duct. Does this make sense? So the saliva becomes more isotonic because sodium and chloride concentration does not decrease or increases basically. Okay, potassium concentration increases significantly. No, there is no time for potassium secretion into the saliva. Bicarbonate concentration decreases, making the saliva more acidic. Could be, but the more correct answer will be saliva becomes more isotonic. All right,
I have a
now,
question.
yeah, go ahead.
Uh, can you go back to the question?
Yeah, sure.
Okay, I agree with you that it's isotonic, but
Mhm.
sodium and chloride they're being reabsorbed, but to a lesser extent. Fast flow is gonna how is it gonna like increase the concentration and not decrease?
Okay, so we're saying that at high flow rates, the saliva that is produced here, can you see my pointer? I'll use this
Yes.
one. Okay, so the saliva that is produced here is spending less time in the ducts. Okay, so if you have less time in the ducts, that means the reabsorption will be increased, right? It decreased. There will be less reabsorption of sodium and chloride from the saliva into the cells. Okay, which will result in sodium chloride concentration of the saliva increasing, which is what this option says. Look here. It says saliva becomes more isotonic, sodium chloride concentration increase in the saliva because less is being reabsorbed from the saliva. Does that make sense?
Yes, thank you.
Okay, you're welcome. And then we talked about how saliva is produced. It becomes more hypotonic as it passes through the ductal cells. And then we have some factors that increase or decrease saliva secretion. So obviously sympathetic nervous system, we don't have, it's basically fight or flight, right? So we don't have time for secreting saliva or resting and digesting, which is what the parasympathetic nervous system does, right? So when you have sympathetic nervous system activation, you will have secretion of small amounts of viscous saliva. Okay, whereas if you have PSNS or parasympathetic activation, this will cause increase in IP3 and calcium, which will secrete large amounts of saliva with low concentration of organic molecules. And then this part says that they work together, etc., etc. All right. moving on to the next question. If you guys have any questions at any time, please let me know. Okay. Next question. 55-year-old man presents with chronic heartburn, regurgitation, especially when lying down. Esophageal monitoring shows frequent episodes of acidity. Which of the following best explains the physiology of his condition? Okay, B. Any other answers? The answer is B. You're right again, mashallah. Okay, so here we're talking about GERD or gastroesophageal reflux disease, which is caused by decrease in lower esophageal sphincter tone, which causes reflux of gastric contents up into the esophagus, right? So that is the pathophysiology of GERD, and yep, pretty straightforward question. All right, next question. 42-year-old woman presents with progressive dysphagia for both solids and liquids, along with regurgitation. Barham's swallow findings are shown in the figure below. Which of the following explains these findings? That's fine. Okay, so let's think together. If you have increase in inhibitory neuron activity, will that decrease or increase the lower esophageal sphincter tone? It should. Wait, let me think actually. Yeah, if you have increase in inhibitory, it should decrease the lower esophageal sphincter tone, which means this should cause, yeah, it should decrease, which means it should not result in aperistalsis or anything. It should make it relax, right? Which should cause reflux of contents, not really this disease. What is this disease, by the way? Okay, so this is achalasia. I don't know if you guys paid it, like if the doctor paid or like put emphasis on this, but this is a very like important disease, very like high yield. It comes everywhere. So achalasia is basically, second, okay. Achalasia is basically increase in degeneration of the myenteric plexus, which causes uh, inhibitory neurons to be degenerated. So if you have loss of inhibitory neurons, this will cause more of contraction because inhibitory neurons result in relaxation, right? Excitatory neurons is what causes the contraction. So this is achalasia. And this is where you have loss of inhibitory neurons, which results in excessive contraction. So as you can see in here, the lower esophageal sphincter is so contracted that nothing is able to pass through. And this disease is called achalasia. And on X-ray or barium swallow, sorry, you will see a bird beak appearance. Okay, so this is a classical finding seen in achalasia, and behind this or like above this constriction, you will see a proximal dilation of the esophagus because of the accumulation of contents of or food. Okay, so the answer here is B. You have increase in degeneration of inhibitory neurons, which increases the lower esophageal sphincter tone, which decreases esophageal motility. And this is why you see this dilation. Okay, now this might be a bit of a difficult question, but a person with brainstem damage, further evaluation shows impaired coordination between pharyngeal and esophageal phases. Which of the following is the most likely physiological explanation for this dysfunction? I'm sorry if these questions are a bit difficult, but I, yeah, I think it's better to practice difficult questions so that you can answer easier ones in the exam, hopefully. Okay, so I'll answer this question if it's difficult. The answer here is A. It is damage to the swelling center in the medulla. We know that the swallowing reflex has a swelling is initiated from the swallowing center of the medulla. It has three phases. You have the oral phase, the pharyngeal phase, and then the esophageal phase. I'll go more into it when I recap the lecture. Okay, so here it is. So in P4, you guys took the swallowing reflex. You have the oral phase, the pharyngeal phase, and then the esophageal phase. So the oral phase or the first phase of the swallowing reflex is the only part that is voluntary. However, when the tongue pushes back the bolus and the palatopharyngeal folds sense the food at the back of the mouth, and this triggers the swallowing reflex. And from then on, this swallowing reflex is involuntary. Okay, so yep, that's all about the swallowing reflex. You can just read these descriptions here. In this lecture, you also took about the esophagus and everything about the esophagus. So the upper third of the esophagus is striated muscles only or skeletal muscles only. The middle third is a mix of striated and smooth muscles. And the lower third is a mix is only smooth muscles. That's something that you just have to know. You know it from anatomy as well, I believe. Then this is what a normal esophageal manometry looks like. A manometry is basically pressure measurements at different parts of the esophagus. So as you can see, when you swallow a bolus of food, you have opening of the upper esophageal sphincter, so the pressure goes down, and then it increases back again. So to prevent reflux of food from the esophagus back to the mouth, right? And then you have peristalsis going down, 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 and then you have receptive relaxation of the lower esophageal sphincter and the proximal stomach so that food can enter the esophagus and the stomach. And this is mediated by vagus. Okay, then you guys took about a talk about achalasia, which I also briefly touched upon. As I said, loss of inhibitory neurons resulting in excessive contraction and prevention of food going from the esophagus to the stomach. Okay, it has a classical bird beak appearance, etc., etc. Okay, then you have gastroesophageal reflux disease. I also had a question on that, and that is basically decrease of lower esophageal sphincter tone because of whatever reason. The reasons could be increase in intra-abdominal pressure. So if someone has obesity or if someone is pregnant or for any reason there is abdominal distension and a decrease in lower esophageal sphincter tone, this will cause reflux of contents from the stomach to back to the esophagus. Okay, and contents of the stomach include the acid, right? So this will also include the acid, and this can cause feelings of heartburn. And if this continues, this will have Barrett's esophagus, even esophageal cancer, maybe, etc., etc. Okay, so this is what the manometry looks like in achalasia. You can see that the upper esophagus is yeah, this is normal, sorry. In achalasia, it is all normal except for the lower esophageal sphincter, which you can see the normal is much lower, at a much lower pressure compared to the, what do you call it, to the esophagus and achalasia. And even when the food bolus comes, the decrease in pressure that should be there is way less compared to normal. All right, this is all about lecture 4. Okay, then next question. 53-year-old man undergoes total gastrectomy due to early gastric cancer. What you would counsel the patient for lifelong supplementation? Which of the following is the most critical supplement? Okay, we have an answer, E. Let's see if you're right. You are right. Good job, mashallah. Okay, so here, gastrectomy means removal of the stomach because of gastric cancer here. And here, water-soluble vitamins, specifically vitamin B12, is very important to be supplemented in such a patient because of the decrease of production of intrinsic factors that are normally produced by parietal cells in the stomach. All right? And that's it. Medium chain triglycerides, no need because they're directly absorbed. Gastrin, you don't need it because gastrin acts on the stomach. And if there is no stomach, you don't need gastrin. Hydrochloric acid, again, hydrochloric acid, it is supposed to act on the stomach. If you don't have the stomach, you don't really need it. However, hydrochloric acid also causes absorption of iron, so you might need to supplement iron, but not necessarily hydrochloric acid. Yeah, all right. And gastric enzymes, you could give them gastric enzymes, but the thing is, there are pancreatic enzymes which are much more potent, and they can kind of compensate for the lost gastric enzymes. All right, next question. Image below shows membrane potential fluctuations and GI smooth muscle. Which of the following best describes the graphs attached? Okay, we have an answer. A. All right, A. Let's see if the answer is A. No, the answer is C. Okay, let's go through this. All right, so A suggests that graph C is taken at rest, and graph B is when substance P acts on the smooth muscle. So here, the main concept they're testing is what happens at rest and what are the inhibitory versus excitatory neurotransmitters, okay? Or excitatory kind of substances, basically. All right, so I think the mistake here is that graph C is not taken at rest. At rest, you still have some contractions. This is taken directly from the slides, by the way. I just made it black and white to confuse people. Okay, so at this graph, A is taken at rest, B is taken when you have excessive stimulation, or not excessive, like stimulation, and C is taken when you have inhibition of the neurons. Okay, so yeah, as you correctly mentioned. So A is at rest, you still have some spikes. B is when you have stimulation. Stimulation is through acetylcholine and substance P, whereas inhibition is through VIP and nitric oxide or NO. Okay, so here graph A is taken at rest, correct? And graph C is the effect of acetylcholine on the smooth muscle. Wait, hold up. Graph C is effect of acetylcholine. Should this be acetylcholine or VIP and NO? I think this is there's a mistake here. This should be graph C is the effect of VIP and NO because that's the inhibitory part of the inhibitory neurons, right? Inhibitory kind of influence on the neurons. So acetylcholine should be this should be VIP or NO. I'm sorry if this question confused you, but I hope the concept is clear. Okay, next question. So, short question, which of the following factors do not typically induce vomiting? Postrema is basically where the chemoreceptor trigger zone is present. If you guys haven't taken this, it is one of the stimulants of vomiting. E, okay. Let's see if it is E. The answer is D, unfortunately. Let's go this. It's a common mistake. Okay, so which of the factors normally do not induce vomiting? So morphine, it induces vomiting. Increase in gastric pressure makes sense. Anything that causes increase in intra-abdominal pressure, you want to expel it out, right? So it can induce vomiting. Stimulation of the area postrema. I'm sorry if you guys didn't take this, but it was there in the lecture, which is why I put it. It will cause vomiting because it contains the chemoreceptor trigger zone. And D, irritation of colonic mucosa. So colon is way below the stomach, right? It is way after the particles are digested and they almost form feces, right? So if you have irritation of the colon, you can't really regurgitate it back from the mouth, right? So that would cause more of diarrhea as opposed to vomiting. So I hope that makes sense. So irritation of the colonic mucosa is something that does not induce vomiting, but distension of the gastric mucosa causes vomiting because, again, if you have any distension or increase in intergastric pressure, it can cause vomiting to expel the nutrients or expel the food. All right, next question quickly. A 45-year-old man presents with epigastric pain, bloating, occasional nausea. Your breath test confirms H. pylori infection. Which of the following is the most likely physiological consequence of chronic H. pylori infection? Okay, let's see what the answer is. So the answer is C. So it causes increase in gastric acid secretion due to decreased somatostatin release. Okay, so we'll just recap the lectures quickly, 5 and 6. So lecture 5 and 6 talk about mostly everything that's happening in after the esophagus, so the stomach now, right? So the stomach has mainly two types of glands, the pyloric glands and the gastric glands. And the gastric glands are in the gastric mucosa, which contains different types of cells, as you can see. Parietal cells, mucous neck cells produce mucus bicarbonate, parietal cells produce gastric acid and intrinsic factor as well, as I mentioned previously. ECL cells produce histamine, which in turn stimulate gastrin, if I'm not wrong, to produce hydrochloric acid. Then we have chief cells, which produce pepsinogen, which is converted to pepsin in acidic conditions. And then we have D cells, which secrete somatostatin, again, the hater, which basically inhibits everything. Then we have G cells, which produce gastrin, which increases the mucosa of the stomach, etc., etc. All right, then you guys talked about the phases of gastric digestion, which include the cephalic, gastric, and the enteral phase. So cephalic phase is the first 30%. It is basically when you smell or you see or you taste a food for the first time, and it is mediated by vagus nerve, and it causes its effects through parietal and gastric cells. Okay, a gastrin secretion, sorry, in the stomach. So whenever you smell the food, gastrin secretion will already be starting through the cephalic phase. Okay, then we come to the main phase, which is the gastric phase. And this happens because of distension or bloat, kind of increase in size or distension caused by the food actually being in the stomach, right? So this distension and amino acids, peptides, etc., all of this cause, again, it will cause gastrin secretion and parietal cell activation and all of that to secrete more of acid and enzymes from the stomach. Then you have the enteral phase, which is the last phase, and we'll go to in the future lectures. This mainly it sees the acid concentration of the food that goes to the duodenum, and it inhibits or activates the HCl production based on that. Okay, so through negative feedback, it either inhibits HCl production if it is too acidic, or it does not inhibit. That's basically it. Okay, and then we have on this side the different kind of substances that affect the acid secretion. Okay, so acetylcholine, it increases acid secretion through muscarinic receptor, gastrin, also increases, as we said, histamine also increases. Somatostatin, however, it inhibits, and prostaglandin also inhibits gastric acid secretion through GI, or the inhibitory guanylyl cyclase, cell signaling molecule, basically. All right, so I hope this makes sense. A bit more, since these are two lectures. So there are some factors which inhibit HCl secretion, some factors which do not inhibit. So in the stomach, if you have increase in acidity, you will have increase in somatostatin and decrease in gastrin, which makes sense because you want to decrease the acidity now, which will inhibit the parietal cells. And this will decrease the acid production. Similarly, in the duodenum, as I mentioned before, if you have increase in acidity of the chyme is basically the food bolus that has gone through the stomach. If you have increase in acidity of the chyme, you will have, or if you have hypertonic solutions, this will increase the secretion of secretin or GIP or CCK or somatostatin, and these will all work on inhibiting the parietal cells and will decrease the acid production. Okay, and also the long and short reflexes are also involved here. Okay, then we have the basal electric rhythm of the gut. If you guys can guess, what type of cells in the mucus, the stomach or the GIT produce or it's called the pacemaker cells. It is the interstitial cells of Cajal. Okay, then you have relaxation of stomach. So relaxation of stomach can be of three types. You have receptive, adaptive, and feedback relaxation. Receptive is through swallowing. Adaptive is because of distension of the stomach, and feedback is because of presence of nutrients in the intestine, which feed back and cause relaxation of the stomach, right? And so if you do a vagotomy, or if you remove the vagus nerve, this will cause the adaptive relaxation to be impaired, which is something that you that I saw in the practice questions that your doctor gave you. So it is something to keep in mind. Okay. All right. Then we have you guys took about stomach emptying, and you also took the vomiting reflex. As I mentioned before, it can be caused by overdistension or any kind of irritation to the upper GIT. Okay, not the lower GIT. Irritation to the lower GIT will cause diarrhea, whereas irritation of the upper GIT will cause vomiting. All right. And also the vomiting center is in the medulla. And you have the chemoreceptor trigger zone in the area postrema, which is also involved in vomiting. Lastly, we talked about peptic ulcer disease. Peptic ulcer disease is basically an ulcer in the stomach, right? Or the duodenum, or anywhere in the GIT. Not really anywhere, stomach or duodenum, basically. So peptic ulcer means erosion of the mucosa or loss of the mucosal barrier. And it can be caused by a lot of different things. It can be caused by NSAIDs, can be caused by gastrinoma or Zollinger-Ellison syndrome, or it can be caused by H. pylori. These are the three things that are mentioned in the slides, which is what I'm trying to cover as well. So what H. pylori does is it produces urease, and this helps it colonize through the acid of the mucosa, right? Even though the mucosa is acidic, it can still colonize because it produces urease, which produces an ammonium-like alkaline coating. So it can still go through the acidic environment of the stomach. All right, then it decreases somatostatin, and it causes inflammation and infection, and all of these result in increase in acid, decrease in bicarbonate. So increase in acid, decrease in bicarbonate will cause erosion or irritation of the mucosa through increase in acid, right? Which will result in duodenal ulcer most commonly. All right, that's it for lectures 5 and 6. Again, if you have any questions, feel free to stop me anytime. Here's the next question. So, 42-year-old man presents with multiple peptic ulcers, chronic diarrhea, abdominal pain, markedly elevated gastrin levels despite acidic gastric pH. What is the primary pathophysiological mechanism behind this condition? All right, as you correctly mentioned, it is B. Can you tell me what disease this is? All right, this is gastrinoma or Zollinger-Ellison syndrome. Okay, so this is where you have a gastrin-secreting tumor, which results in increase in gastric acid production, and this gastric acid is not responsive to negative feedback caused by the acidic gastric pH, which is why this information is mentioned. All right, next question. So, a 50-year-old man with a history of chronic alcohol use presents with severe epigastric pain radiating to the back, nausea and vomiting. Serum amylase and lipase are significantly elevated. What is the primary mechanism underlying the pancreatic injury? So this is basically talking about pancreatitis. Okay. B again, let's see. And it's correct. Inshallah, exam will be smooth sailing for you, inshallah. All right, so this is acute pancreatitis, which classically presents with this pain radiating to the back, nausea, vomiting, increase in serum amylase and lipase, and this is caused by premature activation of trypsinogen or any other pancreatic enzymes within the pancreas, right? So increase in these enzymes will cause the pancreas to digest itself. So it's called autodigestion of the pancreas, and this will cause pancreatitis. All right, next question. A 5-year-old child with a history of recurrent respiratory infections, steatorrhea, failure to thrive, diagnosed with cystic fibrosis. How does this condition primarily affect pancreatic function? Okay, the answer here is B. So what happens here is in cystic fibrosis, I don't know, I didn't see that you guys took it in detail. However, it is something that was one of the practice questions, and that's why I included it here. So what cystic fibrosis does is it is a mutation in the CFTR protein, which increases chloride in secretions, any kind of secretion, sweat, bile, pancreatic secretions, etc. All kinds of secretions will have increased in chloride, which will cause the mucus to be thickened, and this will lead to enzyme deficiency. All right, so this is something that you just have to know, basically. All right, so lecture 7 was pretty small. It basically talks about everything about the pancreas. So the pancreatic secretion, first starting with the stimulus. So what stimulates pancreatic secretions? It can be acetylcholine, it can be cholecystokinin, and it can be secretin. The main three substances which stimulate the pancreas to secrete its enzymes. So the acetylcholine and cholecystokinin, they mostly affect the acinar cells, whereas the secretin affects mostly the ductal cells. So the acetylcholine, CCK, they produce the enzymes mostly, whereas the secretin adds the water and the sodium carbonate, etc., to the mixture or the pancreatic juice, basically. All right, this is secreted through a calcium-dependent pathway, and the enzymes are secreted as zymogens, right? So they're not secreted in their active form, rather in their inactive form. Because if they're secreted in their active form, they're going to digest the pancreas itself. This is what happens in acute pancreatitis, right? So we need to secrete it in a, what do you call it? In an inactive form. All right, these go to the duodenum through the ampulla, what do you call it? Through the sphincter of Oddi in the duodenum, and then they get activated. Okay, so they can be activated if they're proteolytic enzymes, they're activated through enterokinase and trypsin, whereas if they're lipolytic enzymes, they are activated by the alkaline medium of the duodenum. All right, okay, then you guys, this is activation, secretion, stimulus, and then the pancreatitis we mentioned, it's a classic pain that radiates to the back, and it is caused by increase in production of the yeah. So it is caused by immature activation of pancreatic enzymes within the ducts, which results in autodigestion of the pancreas itself. All right, then we have the Zollinger-Ellison syndrome, which is basically gastrinoma, as I mentioned. It's an ectopic production of gastrin, which results in kind of increase in gastric acid despite increase in acidity of the stomach. So it is not responsive to negative feedback. Okay, and this diagram basically shows all the cholecystokinin, secretin, and acetylcholine that affects the pancreatic enzyme secretion. All right, moving on to next question. Which of the following is the primary mechanism by which iron is absorbed in the duodenum? Okay, B again. Let's see if it is B again. All right, yeah, you're right again. Okay, mashallah. All right, so it is B. Heme iron is absorbed through a specific heme transporter, and non-heme is absorbed as ferrous iron via DMT1. So we'll go through the pathway just quickly. Before that, let's solve the next question of this lecture. So which of the following statements regarding intestinal absorption is correct? Okay, let's see if the answer is C. And you're right, yeah, it is C. Okay, so let's go through the options one by one, just in case anyone's confused. So most water absorption occurs in the large intestine. This is not true. Most of the water absorption occurs in the small intestine. Can someone tell me where exactly in the small intestine the maximum amount of water is absorbed? Jejunum, yes, perfect. Okay, and then we have option B, sodium absorption occurs only through sodium glucose cotransporter, SGLT1. It's not true. There are other cotransporters or other transporters in general which also cause sodium absorption. Option C is correct. Option D, vitamin B12 is absorbed in the duodenum. This is not true. Vitamin B12 is absorbed in the terminal ileum. Yes, exactly. Perfect. And then option E, jejunum is the primary site for bile salt absorption. This is again not true. Can you tell me where bile salt is primarily absorbed? Also the ileum. Good. Perfect. Okay, so this is a recap of lecture 9. So lecture 9 mainly talks about the absorption of small and large intestine. So these are some like very like high yield key points to know. So jejunum has a net absorption of sodium bicarbonate, and also, as you correctly mentioned, the maximum amount of water is reabsorbed. Ileum, it absorbs NaCl, and it has a net absorption of NaCl and also vitamin B12. Sorry. Colon, it absorbs sodium and it secretes potassium, and it also has the effect of aldosterone in it. Large intestines contain the sodium potassium 2 chloride transporter. Then duodenum absorbs iron, and ileum absorbs B12, as I mentioned. All right, so these are just some things that keep coming over and over in the MCQs. And now a bit about iron absorption. So there is heme iron, there is non-heme iron. Okay, so heme is directly transported in, and it is broken down into porphyrin and iron, ferrous iron. Ferrous is 2+, ferric is 3+. So it is absorbed as ferrous, and then it is taken in through the ferroportin channel. Whereas for non-heme iron, it has to be taken in through the DMT1 transporter, if it is ferrous. Okay, so if it is ferrous, it is directly taken in through DMT1. However, if it is non-ferrous or if it is ferric, which is 3+, it has to be first converted to ferrous and then taken in through this DMT1 channel. So now, can you tell me, if I want to give a person with iron deficiency, iron, should I give ferric or ferrous sulfate? Ferrous, perfect, because it can be directly absorbed through DMT1, which will increase absorption, increase kind of efficiency of the drug or the supplement, right? Okay. So then this is something you can go in your own time. So go over in your own time. So basically, when you have hypovolemia, the sympathetic nervous systems get activated, angiotensin 2 gets activated, and all of these work on the jejunum, ileum, and the colon, most effectively on the jejunum to increase the water reabsorption so that the volume increases. All right, going strong, guys. So this is a table that I found online, and it is very helpful in my opinion. This states all the main nutrients absorbed and the key transporters and just the clinical significance, etc. So you can go over it in your own time. These are some high yield info as well. All right, next question. 60-year-old man with chronic constipation advised to increase his fiber intake. The defecation reflex, I don't know why we jumped here, but is primarily mediated by which of the following physiological mechanisms? Okay, someone says A. All right, let's see if the answer is A, and you're right once again. Okay, yes, the answer is A. So relaxation of the internal anal sphincter via parasympathetic stimulation, which makes sense because parasympathetic means rest and digest. It wants to relax all the sphincters, it wants to increase secretions, it wants the body to basically digest and work on the GI all the time. Whereas the sympathetic is like we don't have time for GI, we need to fight or flight. So all the GI kind of functions, secretions, sphincter, they're all inhibited. All right. Yep, so you're right. Next question. Which of the following statements about large intestinal motility are correct? Okay. So someone says B. Let's see if it's B. It is B. Once again, very good. Okay. So here, let's go through the options. Haustral contractions or slow segmental contractions primarily function to propel food forward. This is wrong. Segmentation is mainly to reabsorb more sodium and water and electrolytes, etc. It is not to propel the food forward. Peristalsis, on the other hand, or mass movements, are responsible for propelling the food forward, which is option B. Retroperistalsis occurs frequently in the colon. No, it does not happen in the colon. It happens during vomiting, and it can happen during the defecation reflex if uh, the condition or the situation is inappropriate for defecation, which is when we can have retroperistalsis to kind of keep the feces inside the rectum. Okay. And colonic transition time significantly faster? No, it is actually very way slower. Gastrocolic reflex inhibits large bowel motility to prevent, no, it should increase bowel motility because you digested the food, so now you want to excrete the food or defecate, right? All right, so this is a small recap on P10. So lecture 10 talks about intestinal motility mostly, so segmentation, peristalsis, and retroperistalsis. So segmentation happens on the most commonly or most significantly in the ascending colon and the cecum and the ascending colon and maybe a part of the transverse colon. So segmentation or haustral contractions are basically kind of just to segment or to give time for the chyme, it's still not called feces, for it to absorb more water and electrolytes, etc until it reaches the transverse colon. And then after the transverse colon, you want to, okay, خلاص, you're done digesting, you want to now expel the feces, right? So that's when you have peristalsis. So peristalsis propels the food forward and it does, what do you call it? Uh, It does propulsion and peristalsis, yeah. And hostile segmentation, it does not do propulsion forward. It is mainly just for absorption, as I said. Okay, then you have retroperistalsis in the rectum, as I mentioned, and okay, what else? You also took colonic fermentation. So the bacteria in the colon, it converts carbohydrate to different byproducts, and this is if the feces is in the colon for a short amount of time. However, if the feces is in the colon for a long amount of time, these colonic bacteria will use up all the carbohydrate, and then they'll start digesting the protein. So once they start digesting the protein, it will produce ammonium and other byproducts, which are actually harmful for the gut and can even be carcinogenic. So this is a concept that you guys studied. And also, lastly, there's the defecation reflex. So this is very important. So in the defecation reflex, once the feces reaches the rectum, you will have contraction of the rectum, and then you'll have relaxation of the internal anal sphincter. All right, internal anal sphincter. So both of these are parasympathetic. They are not, they are autonomic, basically. They are not somatic. Then you have the external anal sphincter, which is controlled by the somatic pudendal nerve. And this is voluntary, right? So if the situation is convenient to defecate, this will cause relaxation of the sphincter. Otherwise, it will cause constriction of the sphincter, and this will determine whether you have fecal continence or no. Okay. All right. Now that's it for lecture 10, I believe. Okay. We're reaching the end almost. Okay. Which of the following correctly describes the enterohepatic circulation of bile salts? B. Okay, let's see if it is B. Oops, the answer is A. Primary bile salts are reabsorbed in the terminal ileum via active transport and recycled back to the liver. So we'll kind of go over the enterohepatic circulation and all that. Then we have the other options. Bile acids are excreted in stool without undergoing intrahepatic cycling? No, actually, almost 80 to 90% of bile salts are recycled back for about 4 to 6 cycles, approximately, if I'm not wrong. And then bile salts undergo significant deconjugation in the duodenum, leading to loss of function. This is not true. Again, if it underwent loss of function, then it wouldn't make sense to kind of send the bile to the duodenum. And then liver synthesizes primary bile salts de novo with each meal. That is not true. Only 5 to 10% is synthesized de novo. The other 85 to 90% comes from the recycled, what do you call it? Bile. Okay. Then secondary bile salts are more hydrophilic and absorbed passively in the jejunum. This is also just simply not true, and it's just something that you have to know. Okay. So we'll go to the bile synthesis and all of that, but before that, another question. 45-year-old woman presents with postprandial right upper quadrant pain and bloating. Ultrasound confirms gallstones. Which of the following alterations in the bile composition is most likely responsible for her condition? Easy question, inshallah. Yes, as you correctly mentioned, the answer is D, supersaturation of cholesterol. Okay, yeah, you're right. The answer is D. So now just to recap, lecture 11 first starts with triglyceride metabolism. So triglycerides are taken in, and then they are emulsified using bile, and they form micelles, which on which the pancreatic lipase can then work. Sorry. And the pancreatic cells then produce fatty acids and monoglycerides, right? So these then go to the enterocyte, and then they're resynthesized, reesterified, and then taken away through the lymph ducts in the form of chylomicrons. Sorry, excuse me. Okay, In this lecture, you also took everything about bile, so bile synthesis, bile conjugation, intrahepatic circulation. I hope I have some. Yeah, so I couldn't find summary tables. For this, I think the slides kind of, even though it looks a bit intimidating, it does comprehensively mention everything. So, first of all, synthesis of bile, it is produced from cholesterol, and it uses the enzyme 7 alpha hydroxylase, which is very, very important. And this is the rate-limiting enzyme of this synthesis. Now, the primary bile acids are cholic acid and chenodeoxycholic acid, which then is conjugated by the hepatocytes using glucose or glycine and taurine to produce glycocholic acid and taurochenodeoxycholic acid. Okay, now these are taken to the duodenum where they form back either by deconjugation, they form glycocholic acid and this taurodeoxy. They are either deconjugated with through the bacteria or they're converted into secondary bile acids. Secondary bile acids are called deoxycholic acid and lithocholic acid. Okay, so now, can someone tell me, bile normally, when it is produced by the liver, it goes into the gallbladder and not into the duodenum directly? Can someone tell me why? It has two ways to go. Why does it go to the gallbladder and not the duodenum? Okay, all right, good guess, but something similar to that. It's basically because um, the bile that is produced at the liver, it goes to the gallbladder because the gallbladder is normally or physiologically relaxed, whereas the sphincter of Oddi, which is through which it has to go to the duodenum, is tonically contracted or like always contracted, right? So instead of going through this high pressure or high resistance sphincter to the duodenum, it goes to the gallbladder, which is relaxed. Okay. And one more thing that was mentioned was that the major mechanism of cholecystokinin is through neural stimulation as opposed to hormonal or paracrine stimulation. Okay. All right, that's it for lecture 11. We're almost reaching the end. Okay. Match the component of the liver with its correct function. All right, C. Let's see if you're right once again. Yes, you're right once again, mashallah. The answer is C. So we'll go through all of these again when I do the recap. So periportal zone, periportal zone has a high, actually, let me use the diagram. Yeah, so periportal zone is near the arteries, right? So near the arteries, obviously, you'll have a high concentration of oxygen. And this means you can carry out oxidative phosphorylation, you can uptake bile acids, etc. Whereas the perivenular zone, which is near the veins, which means less oxygen, you can do anaerobic procedures such as anaerobic glycolysis or detoxification of drugs. And since you have less kind of oxygen concentration in the perivenular zone, this area is more sensitive to ischemia. Okay, all right. Moving on to next question. I hope you guys took this. Which of the following best describes the role of UDP glucuronil transferase in the metabolism of bilirubin and the liver? Yeah. Okay, alhamdulillah, you guys took this. So the answer, as you correctly mentioned, it is B. So let's go over bilirubin metabolism. I believe I shouldn't go into much detail since you guys, I'm sure you guys are studying it in more details. I'll just go give you an overview. So first, you have bilirubin, which is produced from the metabolism of hemoglobin or heme, right? So heme is converted to biliverdin, then bilirubin, and this is carried on to the liver, where it is conjugated, as was tested in the previous question, with glucuronic acid to form bilirubin glucuronamide. And this, the enzyme that is responsible for this is UDP glucuronil transferase. Now, this conjugated bilirubin, it goes to the small intestine, where it is deconjugated, where it is converted to urobilinogen. Urobilinogen can be taken in and conjugated again through the liver, or it can convert into stercobilin, which is what gives the feces its brown color. All right, so this is a bit about bilirubin metabolism. Now, we all know about jaundice. So jaundice is what happens when you have accumulation of bilirubin. Okay, so if you have accumulation of bilirubin, it will cause jaundice. This can either be unconjugated or conjugated. Conjugated means it is something, since conjugation happens in the liver, so if you have increase in conjugated, it means that the problem is in the liver or after the liver. So after the conjugation has taken place, right? Whereas if you have unconjugated hyperbilirubinemia, it means that the issue is before even the bilirubin got a chance to get conjugated, right? So this is prehepatic causes usually. So they can be hemolytic anemias, so increase in breakdown, like very what do you call it? Increase in the rate of breakdown of RBCs through hemolytic anemias, or physiological jaundice, something that happens in neonates. Or you have Crigler-Najjar syndrome or Gilbert syndrome. This is when the enzyme that we talked about, UDP glucuronidase transferase, is either absent or it is dysfunctional, right? So you cannot conjugate the bilirubin, which will result in unconjugated hyperbilirubinemia. Posthepatic is conjugated, as I said. It can be caused by gallstones or biliary tract disease or a tumor, anything that blocks the conjugated bilirubin from going out, right? Or it can be because of Dubin-Johnson and Rotor syndrome. I'm not sure if you guys have to know about this because I don't think we had to know about it, but it was mentioned in the slides, which is why I put it in the presentation as well. All right, so these are some of the syndromes that can occur and that can cause jaundice. I'm sorry, I'm not going into details about anything. Now, about liver enzymes, just a bit. I guess you guys just have to know, just have to have an idea. I'm not sure they'll test very deeply in like first year because I don't think it makes sense. Okay, so ALT, AST, they're always high in liver disease. AST more than ALT if it is an alcoholic liver disease. Then you have which is high in gallstones or biliary obstruction. Then you have functional liver markers, which means that if the liver is affected, these things cannot be produced, or these things are produced more than normal, right? So bilirubin, it is produced more than normal. So increased bilirubin, it shows an, what do you call it? A dysfunction of the liver. Albumin is decreased. Prothrombin time is increased because coagulation factors are not released properly, and platelets are decreased. Okay, so if you guys find this very overwhelming, I'm not sure they'll test this actually, but since it's in the slide, I thought I should include it for good measure. All right, so we're almost done. Okay, so which of the following transporters is responsible for glucose and galactose absorption in the small intestine? Oh, okay, someone just mentioned that we don't have to know, which is good, alhamdulillah. All right. C. Let's see if it's C. Yeah, even when you didn't cover the lecture, you got it, mashallah. Okay, so it is SGLT1 transporter. And this is just something, one of those things that you have to know. So in the small intestine, you have a lot of different transporters. You have GLUT2, GLUT5, etc. But the one that carries both glucose and galactose is the SGLT1 transporter. Okay. Um, oops. I think I showed this table by mistake. So pretend you don't see the table. Okay, which of the following best describes osmotic diarrhea? Okay. Let's see if it is D. It is C. It's fine. I'll just go through the four types of diarrhea. So the four types of diarrhea are secretory, osmotic, motility, and inflammatory. Motility related or inflammatory. So secretory is when you have a release of toxins or irreversible opening of the CFTR channel, which causes increase in secretions, as the name suggests, chloride or whatever ion secretions, which causes water to come along with it, and this causes secretory diarrhea. Whereas osmotic diarrhea is because of increase in things or substances inside the lumen, right? So if you have lactose intolerance, or if you have celiac disease, or if you have cystic fibrosis, all of these will increase the amount of solutes in the lumen, which will cause water to come along with it, and this will cause osmotic diarrhea, basically osmosis, right? Then you have motility related diarrhea, which is because of increased motility of the lumen or of the intestine, and this can happen because of vagotomy or neuropathy in diabetes, or change in gastric emptying patterns or dumping sooner. I'm sure you don't have to know about this, but anything that increases the motility will cause motility-related diarrhea. Makes sense. All right, number 4 and the last one is inflammatory diarrhea, which is damage to the intestinal lining. So this can be Crohn's disease or any kind of bacterial or viral infection that causes damage to the lining or inflammation of the lining, right? So self-explanatory. Okay. All right, I think this is one of the last questions. Which part of the GIT is responsible for B12? I think we already talked about this. So you mentioned C, and the answer is C. So terminal ileum is responsible for B12. You are right. Yeah. So for P13, I didn't really add any recap slides because I found it to be very similar to the other lectures. So I think that covers most, if not all, of GI Physio. I really tried my best to kind of summarize everything. If you guys have any questions at any time, feel free to reach out to me. My number is here. It's on the first slide. And if you guys could give any recommendations or suggestions, please fill out this QR code. And that's it for my session. If you guys have any questions or any comments, that would be welcome.